Hello everyone, my name is Dr. Bandula Samarasinghe. I am a general surgeon and a senior lecturer in surgery in Faculty of Medicine. Today our topic is actually gastrectomy, colectomy and appendicectomy. However, all these three operations carry something common. That is, all these organs are located in abdominal cavity or in the peritoneum. Therefore, to operate on these organs, we need to go through the abdominal wall. So, incisions are made in anterior abdominal wall in order to carry out these operations. Although we name them as different surgeries, from physiotherapy point of view, more or less they are same. However, there are regional variations in the anatomy and pain and subsequent management of different operations. So we'll go one by one. So as I mentioned earlier, today this lecture is concentrated on gastrectomy, colectomy and appendicectomy. Gastrectomy involves operations involving the stomach. In colectomy, we operate on colon or the large bowel. An appendicectomy, all of you may be familiar with that. It's an appendicular organ in your gastrointestinal tract. It is common, although its removal is simple, has to go through your anterior abdominal wall. In later slides, we see this in detail. Let's start with gastrectomy. So before anything, let's see what is this ectomy. You must have heard gastrectomy, colectomy, mastectomy, lumpectomy, lot of things ending with ectomy. Ending with ectomy means you remove it. Surgically you take it out from the body and you do not reimplant it in the body. So ectomy means surgical removal. When we talk about gastrectomy, it involves removal of stomach. As you know, stomach is the first part of gastrointestinal tract in the abdominal cavity. Your gastrointestinal tract starts from your mouth and then to the esophagus, and the esophagus is located in thorax. However, in abdominal cavity, where most of the gastrointestinal tract lies, starts with stomach or gastrium. So, sometimes we might have to take the whole stomach out. Then we call it total gastrectomy. Or sometimes we might have to take only a part of it. Then we call it partial gastrectomy. So first of all, let's begin with some anatomy of the stomach. Anatomy is a J-shaped hollow viscera or organ in your abdominal cavity, and it starts as the continuation of esophagus. Stomach has several parts. The upper dilated part is called fundus. Then centrally you have stomach body and it ends up in antrum. This region just before the pylorus is called antrum, and in pyloric canal it ends up opening into the duodenum. And the food is mainly stored and digested in stomach. It is regulated by upper sphincter, gastric sphincter, and pyloric sphincter at the distal end. Stomach is a distensible organ, and inside it you see a lot of mucosal folds. These are known as rugae. More importantly, where the stomach is situated. The stomach is situated in upper part of your abdominal cavity of peritoneum. Most of the stomach is covered by diaphragm, that is, inside the abdomen it has gone into the thorax. So why do we want to remove stomach, or why do we want to operate on stomach? There are several reasons. It may be due to cancer. In stomach, you can get carcinomas or cancers. They are called adenocarcinomas. Most of the time these cancers occur in relation to antral region, as you saw in that picture in previous slide, or near the gastroesophageal junction, and commonly it is seen in greater curvature than the lesser curvature. The second one is a ulcer. Ulcer is a kind of wound. There is breach of mucosa inside the gastric wall. Here, this ulcer or wound, which occurs commonly as a result of gastritis, can erode into the gastric wall, and ultimately it can rupture. If it ruptures, it allows gastric contents, which are not sterile, to pass into the peritoneal cavity. This peritoneal cavity is a sterile container. Then patient can develop a condition called sepsis, where germs can spread all over the body and patient can go into serious conditions, and sometimes they might die. Sometimes these ulcers, without rupturing, they can erode into a blood vessel. In that case, you will get uncontrollable bleeding or hemorrhage into the upper gastrointestinal tract. It might manifest as hematemesis, bleeding or vomiting of blood, or passing blood through the rectum. Or sometimes you might have to remove part of stomach as a part of another surgery. For example, if you do a esophagectomy or lower esophageal cancer, you might have to remove a part of stomach. If you do a Whipple's operation for the cancer in the head of the pancreas, you might have to remove distal half of stomach. These are the indications for operations on stomach. During these surgeries involving gastrectomy or partial gastrectomy, whatever, what are the problems we should anticipate from your point of view? That is, from the point of a physiotherapist. So these patients, they are generally old patients for cancers. Ulcers you might come across even in younger patients, but majority of these patients are older. Therefore, you have to anticipate there are age-related problems like reduced mobility. They may have existing lung diseases. So, the chest physiotherapy, you might have to embark more. Nutrition. Sometimes these people are nutritionally depleted. For example, if you have a cancer in the distal end of stomach, it might impair with your proper feeding. Therefore, there may be nutritional problems. When in the presence of nutritional problems, their physical strength, immunity, and all other things will be impaired. Therefore, you might have to pay more attention, more particular attention when you embark on physiotherapy. Some patients may be smokers, and as you know, smoking affects your lungs. Patients may be having chronic obstructive airway diseases. All these things again you should consider when you make a plan for physiotherapy. Sometimes there is risk of aspiration. Aspiration means uh, contents in your gastrointestinal tract might accidentally go into your tracheobronchial tree, that is, into lungs. In that case, there may be choking attacks. Choking attacks means you can't breathe, or patients might develop infections. And after surgery, especially, they are more prone to develop these infections. Therefore, you need to pay special attention on that aspect as well. And since these patients are disease or moribund, sometimes their mobility is limited. They may not be able to walk a long distance or sometimes at all, and that can lead to stasis and collection of secretions in their lungs. There may be associated urinary tract infections. The patient is more prone to develop bed sores. All those things you need to pay attention. Okay, before going into details of operations, let's get an idea about the anatomy of anterior abdominal wall. Your abdominal cavity is the region below your diaphragm. Diaphragm is the structure which separates thorax from the peritoneal cavity or abdominal cavity, and it extends from that level up to the perineum or pelvis, where your lower limb begins. This is mainly a muscular cavity. Posteriorly or from backside, you have your spine, and in upper part of abdominal cavity, it is protected by ribs. Then in lower cavity, posteriorly, it is protected by your hip bone or iliac bones. In between your ribs and iliac bones posteriorly, in addition to your spine, there are strong muscles like erector spinae, psoas major, psoas minor, iliacus. Those are strong, and generally they don't allow hernias and other problems to occur in posterior abdominal wall. And these muscles are very thick. Therefore, we generally don't operate on patients from their backside or the posterior side. When it comes to the anterior side, anterior most, there are two muscles. They are called rectus abdominis muscles. You can see these are longitudinal muscles. They are on either side of the midline or linea alba. It goes through your umbilicus. And this rectus abdominis muscle, as you can see here, there are the fibers doesn't go through the whole length as single fibers, but instead there are interconnected septae. They are called chordae tendineae. Rectus abdominis is enclosed in a structure called rectus sheath. This is a fibrous cover around the rectus abdominis muscle. Inside that lies an important blood vessel called inferior epigastric or superior epigastric arteries. Right. And from these two muscles in the anterior-most abdominal wall and the posterior abdominal wall we described, there are three muscles spanning from behind to forward. The outermost one is the external oblique muscle. External oblique muscle arises from posterior thoracolumbar fascia and spreads anteriorly. As it comes to the anterior surface, it comes in medial and below direction. Ultimately, it join with other tendons of other muscles which I will describe after this, and commonly they uh, fuse with the rectus sheath which I described earlier. Below or inside the external oblique muscle lies your internal oblique muscle. Internal oblique, the same thickness as your external oblique. It also expands from posterior side, but unlike external oblique muscle, it comes forward, and while coming forward, they go towards the head of the patient, that is the medial and superior. That is the direction of muscle fibers. So external oblique and internal oblique muscles fibers cross each other. This will give additional strength for your abdominal wall. Deeper to the internal oblique lies transversus abdominis. It's a relatively weak muscle when you compare it with external oblique and internal oblique. As the name implies, its fibers are transverse. And at the lateral edge of your rectus sheath, all these muscles fuse together. All these muscles become tendons, flat tendons, and they fuse with each other, forming the linea semilunaris. Another important thing about the arrangement of anterior abdominal wall muscles, the nerves and blood vessels, which arise from a posterior part of your body and comes anteriorly in between your internal oblique and transversus abdominis. This anatomical knowledge is important when you give nerve blocks to, to get pain relief after operations. In that case, you have to infiltrate your local anesthetic into the space between transversus abdominis muscle and internal oblique muscle. Okay, let's see how we treat these organs. First, we are talking about gastrectomies. This is a diagram of abdominal cavity. You can see this uh, incomplete line is over the rib cage, and here is your pelvis, and your stomach lies in this region, partly covered by the rib cage and thorax. So if you want to approach stomach, you can use one of these incisions, right subcostal just below the rib cage, or you can use a midline one, and you can use a paramedian one. Generally for stomach you need left paramedian, but you can do a right paramedian as well. Sometimes there's another incision called rooftop incision, where you make an incision like this just below the costal margin on both right and left side. It is called rooftop incision because it's similar to a roof in a house. In addition, especially in young children, we might do a transverse incision to achieve the necessary exposure in gastric surgery. So, what are the muscles which are being cut in this each incision? When you get midline incision, generally it's upper midline incision, you might extend it below the umbilicus level. Here, there is no cutting of muscles. You only cut the linea alba, that is the fibrous raphe which connects to rectus abdominis muscles. For you to reach that, you have to cut the skin in line with this incision, subcutaneous tissue where you get your nerves, and then this linea alba. After that, extraperitoneal tissues and peritoneum. But here in this midline incision, we have to cut lot of nerve endings coming in transverse direction. I will show how nerves are coming into the anterior abdominal wall in a subsequent slide. Therefore, it involves cutting of lot of nerves. If you take right subcostal incision, here it's more or less transverse. So, you cut only few nerves, or you go through only limited number of dermatomes, unlike in midline incision. I'll explain what a dermatome is in a subsequent slide. Left paramedian incision or these are the dermatomes which I described earlier. As you know, all our nerves are arising from spinal cord, and after the spinal cord it comes along the body wall to reach the muscles and skin in the anterior abdominal wall. So they come in an oblique and curved manner. While coming so, they supply the overlying skin, and these are the and one area of skin which is supplied by a single spinal nerve is called the dermatome. So in anterior abdominal wall, these are the dermatomes. Generally, it starts with 6 thoracic nerve, then T7, T8, T9, T10. So around your umbilicus, the nerve which is supply the skin is the 10th thoracic nerve. So in our incisions, it is clear that if we make a longitudinal or midline incision, we have to cut all these dermatomes. There are nerve endings which cross midline, right? Generally, they don't stop at midline. If they stop at midline, then if we do a midline incision, it should be pain-free. But that is not the case. Nerve endings cross the midline and supply the other nasal. Therefore, when we cut midline, we cut nerve endings on both sides. Because of that, its pain is more. Whereas if you make a kind of transverse incision, say you make an incision along this T9 dermatome, you will cut several nerve fibers arising from the same nerve. So the pain fibers of only T9 is stimulated. Right? Therefore, the body perceives this as pain arising in a very small area. Therefore, pain is much less. In post-op management, you need to pay attention for these aspects. Pain. Pain, as I described earlier, pain is more when we have a midline scar. When we have a transverse scar, although we cut several muscles, namely your rectus abdominis muscle, external oblique, internal oblique, and transverse abdominis. All the muscles we have to cut in a transverse incision. However, as I explained earlier, if we go only through one dermatome, the pain is much less. Whatever it is, the pain, since the stomach is closer to your thorax, all respiratory movements will aggravate or will make this pain more. Therefore, the patients might not breathe properly after the operation. They will take only shallow breaths. What happens if they take shallow breaths or reduced breathing? In your respiratory system, that is in lungs, trachea and other respiratory tubes, there are continuous secretions. Those secretions, some will get absorbed, but some has to be taken out. Some of the secretions will come into your larynx and then it is swallowed into your gastrointestinal tract, or sometimes it is spit off or they excrete it. If you don't do that because of reduced breathing movements, there is accumulation of secretions. These secretions can accumulate in your alveoli, the smallest part of lungs. They can collapse. That can cause problems with oxygen supply. In addition, when there are accumulation of secretions, it can lead into infections. Infections in your lungs is known as pneumonias, and this is why post-op patients develop pneumonia. So, the mainstay of preventing post-operative pneumonias lies on your hand, the physiotherapist's hand. Pain relief, although it's the duty of doctor, you also need to pay some attention to that. Even though patient has some pain, you need to devise your physiotherapy methods to prevent accumulation of fluid in lungs and to prevent collapse of parts of lungs. So they should take proper breaths. Because of pain and other discomforts associated with this surgery, the patient's mobility is very limited. They will lie flat on bed. This can lead into a lot of problems. As a physiotherapist, it's your duty to encourage them and help them to achieve early mobility. The respiratory problems we have discussed earlier, so it is very important to prevent atelectasis. Atelectasis is collapse of alveoli and prevention of pneumonias. In addition to respiratory problems, they might develop urinary tract infections. That is due to stasis of urine. One thing is stasis of urine. In addition, after these operations, there may be indwelling catheter in the urinary tract. When you insert an indwelling catheter, although you do it under sterile conditions, there is very small chance of introducing an infection. So it should be taken into account as well. After the operation, when these patients lie flat on beds, they tend to develop a condition called deep vein thrombosis or DVT. This is a serious condition. Blood clots inside veins. It is due to several reasons. One reason is lack of movements. If the patient moves around, their muscles will squeeze the blood inside the veins into the heart. But when they don't do that, blood tend to stagnate there. When blood tends to stagnate, In addition, when you do an operation, the chances of developing a clot is more. This is known as hypercoagulability of blood, and they can develop DVT. What happens if we don't treat DVT? These blood clots inside veins of the limbs can extend into the major veins like inferior vena cava. Inferior vena cava is the largest vessel in the venous system which carries blood into the heart. If there is a clot, a part of clot might detach and it can go along the bloodstream and cause obstruction of your pulmonary artery where blood is going to the lungs. In that case, your whole circulation might stop. Patient can go into a cardiac arrest and dies. Therefore, it is very important to prevent DVT. The most effective way of preventing DVT is early mobilization. You have a big role in doing those things. The patients can do active physiotherapy or passive physiotherapy. So whatever it is, you need to develop some kind of plan to prevent deep vein thrombosis. When patient lies flat for a longer period, they can develop bed sores. That is also known as pressure sores. That is due to the ongoing pressure on bony points. If the patient lies supine on bed, there are particular areas which is more prone to get bed sores. Starting from head, the occipital area, and in between your shoulder blades, and then over your sacrum or your iliac tuberosities, and in heels. So during physiotherapy, pay special attention to those areas to see whether the patient has developed bed sores. Again, like your DVT, the best way of management of bed sores are to prevent. You can prevent bed sore development if you do frequent changes. These bed sores are actually due to ischemia. When the patient lies flat, one of their bony prominences will compress against the soft tissue. So, in other words, the soft tissues will be compressed against the bone and the bed. Therefore, blood supply to that particular area will be lost. If we keep it for a longer period, that soft tissue start dying. Once the soft tissue dies, then there will be a wound. Then contractures. If the patient lies in the same position for a longer period, their muscles and other tendinous structures tend to develop contractures. These are uh, uh, very hard, very hard fibrous strands, so they can't in a joint they can't move the full range. Generally, these contractures develop in relation to flexor surfaces. For example, behind the knee. In that case, they can flex the knee, but they can't extend the knee. So, without extending, a proper function of that limb is not possible. Same thing happens in your elbow and shoulders. So, it is very important to arrange limb physiotherapy so the patients will continue to keep mobility of their joints. Okay, let's move to the next topic, colectomy. I mentioned earlier, colon is the large intestine. So removal of part of colon is colectomy. There are various types of colectomy. Before that, let's see where our colon lies. This is how organs inside our abdominal cavity lies. In this picture, the stomach has been removed. However, it lies in this region. Then, small bowel has also been removed. It's like a worm here. And then, this is the beginning of large bowel or large intestine or beginning of colon. At the beginning of colon, you have the appendix. Generally, this is situated on right side in most of the patient. Very, very rarely, due to malrotation, that is a congenital problem in gastrointestinal tract, appendix might lie here. Then the first part of large intestine is called ascending colon. It's on the right side. Then you have transverse colon, which goes across from right to left of your abdominal cavity in the upper part of abdominal cavity. Then on left side it comes down as descending colon, and in pelvis you get a redundant or mobile part of colon called sigmoid colon, and ultimately it ends up in rectum. So what are the types of colectomies? You will see these kind of names after operations. Right hemicolectomy. In right hemicolectomy, what you do is you remove the cecum, the first part of colon and the ascending colon and part of transverse colon. In extended right hemicolectomy, what you do is you remove cecum, ascending colon, transverse colon up to an area called watershed area. It is something to do with blood supply. In left hemicolectomy, you remove descending colon. Sigmoid colon, as I mentioned earlier, is involvement of that mobile part of colon, right? Then you have two types of resection of rectum. Rectum is the lowest part of your large intestine. In anterior resection of rectum, you approach the rectum through a midline incision most of the time and remove part of rectum. In abdominoperineal resection of rectum, in addition to your anterior incision, there will be another incision around the anus in your perineum. So they might have additional pain and additional incision around the anus, which has been removed during this operation. What are the indications for colonic surgery or removal of part of colon? These are the common ones. Malignancy. This large bowel is one of the commonest area in your gastrointestinal tract where you're likely to encounter cancers. As a part of trauma surgery, large intestine may be damaged, so we might have to take it out. And diverticular disease. It's a hernia-like outpouching of large bowel. You might have to take part of gastrointestinal tract as a result of diverticular disease. Inflammatory bowel disease is a inflammation inside the mucosa, and it can cause bleeding and other problems. If it is uncontrollable, then we might have to remove that diseased part. Volvulus is the rotation of gut along its own axis. Then there may be problems with blood supply and you have to take it out. Or sometimes prophylactically. Prophylactic means before the occurrence of a particular disease, you take that part. If you have a very, very strong family history like adenomatous polyposis coli, then you remove your colon before it develops into a cancer. So, before a patient goes into a colectomy, what should we do? we have to arrange chest physiotherapy. Chest physiotherapy is very important as in our gastrectomy. It will keep their lungs ready for ventilation during the operation. Ventilation is artificial respiration during the operation, and it will reduce complications of in the lungs after the operation. Limb physiotherapy we discussed earlier. They will keep limbs mobile. All joints will have the same range of movements, and in addition, it will help to prevent deep vein thrombosis. Since these large bowel operations tend to occur in pelvis, they are more prone to get deep vein thrombosis. So it is very important limb physiotherapy is done properly. And mobility. If you keep the patient mobile even before the operation, that will help them for a speedy recovery. If you consider incisions, for colectomies, the commonest incision used is midline incision. But unlike in gastrectomy, here we tend to use lower midline incision, more towards the pelvis. In addition, you can use paramedian incision, either left or right. But these paramedian incisions are being done less and less in current practice. Or you can use these gridiron incisions. So what are the structures which you cut during these operations? In midline incision, you have to cut your skin. Generally, our incision goes around umbilicus, or some surgeons might go through the umbilicus. So we cut skin and then subcutaneous tissue where our nerves are situated, and after that the rectus sheath or the linea alba. Once you cut the linea alba, there are extraperitoneal fat. You cut that as well, and the peritoneum. Then you are in peritoneal cavity. In other incisions, away from midline, you cut skin, subcutaneous tissue. In lower part of your abdomen, the subcutaneous tissue is sometimes thick. Sometimes it may be mistaken for deep fascia. Then you cut the deep fascia and its muscles, namely external oblique, internal oblique, and transversus abdominis. In paramedian incisions, you generally don't go into those three muscles. What you do is skin, subcutaneous tissue, anterior rectus sheath, and then you kind of split the rectus abdominis muscle rather than cutting it, and then cutting the posterior rectus sheath before opening the peritoneal cavity. Again, you will appreciate when we do a midline incision, we will go through several dermatomes. So we will cut more and more pain sensitive nerve endings, and pain will be more. After the colectomies, generally there may be a drain or two. Drain, these are plastic tubes which are coming through your anterior abdominal wall muscles. Generally, we take them out from the muscular part. Therefore, they will go through all three muscles: transversus abdominis, internal oblique, and external oblique, and obviously through the skin. So these drains might impair with your physiotherapy sometimes. It can cause pain. So be careful when you do physiotherapy around drains. Then stomas. In the colonic surgeries, there are two kinds of stomas which we might treat. Ileostomy, taking out of small bowel, and colostomy. Ileostomies are taken out on right side generally, whereas colostomies are taken on left side. All these stomas come through anterior abdominal wall muscles. In addition, the fluids might leak and cause skin excoriation. Therefore, it might cause additional pain. And generally, after some time, these stomas heal properly. Once they are healed, say in about 1 month's time, there is no problem of doing whatsoever physiotherapy. But before that, when you arrange anterior abdominal wall physiotherapy, be careful. Don't do any strenuous maneuvers. So post-op again, it is much similar to your gastric surgeries. The patient might have pain. Since we most of the time we do midline incisions, pain may be more. But fortunately, check whether they have a epidural line. Generally, for current patients, the anesthetist insert a epidural catheter. So they can inject they can be injected local anesthetic into the epidural space, which will uh, relieve some pain. Therefore, the important thing is when you start physiotherapy, it is important to get the nurses or doctors to give a shot of epidural top up. That will ease your job. The importance of chest physiotherapy we discussed earlier. You have to do that in order to prevent atelectasis, chest infections, and problems with oxygen saturation. When the patients develop oxygen saturation, they can develop into confusional states, poor wound healing, and lot of other problems. Limb physiotherapy is important. The main thing is to prevent deep vein thrombosis. In addition, it will keep the old joints mobile with full range of movements. Pressure sores, we discussed how to prevent pressure sores. The best maneuver is change the position. Generally, we recommend changing positions once in 20 minutes. If you can do that, then the chances of developing bed sores are much less. In addition, this can be supplemented by providing a water mattress or air mattress. In water mattress, the water may be cool, so there may be problems with keeping the patient's body temperature. Therefore, the air mattress is better than a water mattress. Mobilization. As I mentioned earlier, sometimes it might involve incision in the perineum, in abdominal perineal resection of rectum. So it might cause additional pain when you start mobilizing. But generally, after 2-3 days, you can start mobilization of the patient. Probably you can start with changing to a chair, and you know what to do, I think. After the colectomy, sometimes you might have to give adjuvant treatment. This adjuvant treatment is meant for cancers. You give various cytotoxic cells to kill remaining cancer cells, and you give radiotherapy. So this might cause skin irritation in that relevant area, and it might impair with your physiotherapy. In addition, you need to support them mentally. These are old patients, as we saw earlier, old patients, and they know they have a terminal illness. Therefore, they may be physical, mentally down. If you are mentally down, then your encouragement is also less, so they will take less effort in during physiotherapy. So it is important to motivate them and make them mentally stronger. That will help your process of physiotherapy. Stomas we discussed earlier. During early days, be careful when you do physiotherapy, but after some time, say 1 month, you are free to do whatever you want. Reversing of stoma is another operation. Generally, again, this is done under general anesthesia. Therefore, all the principles we have discussed earlier should be applied. Appendicectomy, the last part of our operation, but most of the things I think we have covered so far. So we can go through this very quickly. Anatomy of appendix you saw, it is situated on right side at the beginning of the large intestine. Therefore, uh, we can approach it through an incision over that region. I will come to that later. Why do people develop appendicitis? Appendicitis is the indication for appendicectomy most of the time. Sometimes it might involve uh, as a part of another operation. In that case, you don't need special uh, physiotherapy arrangement for appendicectomy, but you have to do your physiotherapy for that particular operation. Why do people get appendicitis is due to obstruction of the appendix. Then there is superadded infection. It can lead to rupture of appendix. So to prevent that, we surgically take the appendix out. We control it by ligating the appendicular base and then remove it from the abdominal cavity. You can manage it several ways, this appendicitis. The traditional way is to do a open appendicectomy. In open appendicectomy, what your incision is a gridiron incision. Gridiron incision is a oblique incision where your appendix lies. That point is called McBurney's point. It is situated along a line which connects your umbilicus to the anterior superior iliac spine, and it is 2/3 from midline. So there we make a oblique incision, that is gridiron incision. Sometimes we make a transverse incision at that point. There is no big difference between those two incisions except cosmetic. You cut the same structures. You have to cut through the skin, then superficial fascia. Here we call it scarpa's fascia. It is a bit thick, and then you generally separate the external oblique, internal oblique, and transverse abdominis rather than cutting muscles. However, by doing so, you might damage a few nerve fibers, and then you remove the appendix and you approximate those muscles and close the skin. So it is similar to other operations, but this incision is generally smaller. It causes less pain than the other major operations, and its recovery is much faster. So you can plan your physiotherapy according to the needs of patient. You can think about chest and limb physiotherapy depending on the patient's other mobility. And nowadays we tend to do it laparoscopically, that is with minimally invasive techniques. We make a small incisions around umbilicus, that is 10 mm, that is for camera port, and generally two other ports, only 5 mm incisions just above the pubic symphysis and on left iliac fossa. Those are tiny incisions. Generally they don't cause much of a problem. Here we go through all the muscles, all the muscle layers of anterior abdominal wall, but incision is very, very tiny. And after the operation, generally we infiltrate local anesthetic around the wounds. So pain should be minimal in laparoscopic appendicectomy. And with these corona things, conservative management has also come into picture, where you treat it with antibiotics. When you treat it with antibiotics, you need to keep the patient confined to a bed for a longer period. So, in vulnerable patients, they might develop DVT, pneumonias, and UTIs. So, most of these I told you in early slides. Pain, mobilization, and discharging process. You have to be satisfied before sending the patient. You need to satisfy that patient is fully mobile before discharging. Thank you. And that's the end of my lecture. I don't know whether I have told you too much surgical things, but I try to relate it to a physiotherapy point of view. If you have any questions, please ask Mr. Jinali Manchanayaka. So I can arrange a question and answer session with help of her. Thank you very much again.